to have some Q&A. So if you have a question, would like to raise an issue, or feel like there's points that were made in your small group that the rapporteurs failed to capture, please come to the microphone and make your suggestions. In the meantime, while I wait for you to queue up at the microphone, I see you're already ready, David. So I just want to make an observation. I think we're probably all thinking about it. The expectation I would have had about some of the key challenges and barriers that would be coming out of these discussions would be very technical and thorny methodologic problems, which clearly there are, and there are some really complicated data infrastructure issues that we need to think about if modeling is really going to be exploited to improve population health, and a variety of other issues. But how fascinating the degree of emphasis around engagement of stakeholders in the community and the importance of communication in successful modeling. I think we often give lip service to this point, but I think part of what I'm hearing is there's really a need to take this to the next level in terms of sophistication. The analogy for me is patient engagement, which is something we've often talked about for many years, about patient-centered care and patient-oriented research. But funders like PCORI have now taken it to a high level where that needs to be serious and genuine engagement from the get-go all the way through to dissemination for grants to be considered for funding from PCORI. It sounds like that's kind of the thesis coming out of this, is that meaningful modeling for population health has to get serious about engaging the stakeholders at the very beginning and defining whether they even need the model, what their question is, and then all the way through the validation of the model and its dissemination and communication to stakeholders and the public. David.
Yeah, Dave Kindig, University of Wisconsin. Thanks again to the whole morning and this panel for a lot of great insights. I was sitting here thinking, and this may be an inappropriate thought, let's see, but almost all the examples or the policy areas that we've been talking about influence have been public policy influence, legislators, that whole realm. And I was kind of musing about, are there lessons to be learned from modeling that is done in the corporate sector that we haven't talked about at all that might bear on the way we think about that? I don't know if that's even a naive question. But a derivative of that is, do any of the health care systems, which are nonprofit or private by and large, who must do their own kind of business modeling, are there examples where those models add on some of the health outcomes or other investments in their communities that would sort of go in this direction? So just two thoughts about non-public sector relevance to the conversation.
Do any of you have thoughts on that subject? Do you want to say something, Louise? Or?
I was going to say, mostly I don't think I know much about corporate models. They tend to keep those pretty close to their vest. So I'm not sure how they could inform public decision-making since they don't make the models public. But maybe you know some other.
So the Builders Industry Association in San Diego has done a fair amount of economic modeling of where they're building, what the impacts would be to the economy, to job growth, to dealing even with crime. And so, David, you made me think that there are examples in the private sector that have their modeling. I can't say I studied their models per se, but coming before the legislative body, principle number one, they did business engagement. We talk about community engagement. They did business engagement. They got to the end users and made sure they were involved as they developed their particular model of what they were really trying to influence, in their policy. Now, there may have been some biases in that, but I think that's a good point of looking at across other industries and their modeling and informing us in terms of population health.
And, my impression, and I'm not going to resist a chance to talk, but from my reading on this, the general sense is that we in public health have been behind the curve in adopting advanced kinds of computational modeling and simulation modeling, and that other industries, both in the commercial sector, the defense, national security areas, and many others are quite accustomed to using modeling. Now, the point was made this morning that health and the complex interactions that affect health may be more complicated than a Google search or ordering a product on Amazon. Still, there I think is a more familiar tendency to rely on modeling for management decisions, I think, in the private sector than we've grown accustomed to in public health. George?
So it's a little bit scary. I mean, I've worked with David for a long time. I'm George Isham, co-chair of the roundtable, and my comment actually is similar to yours. So at the end of our session, being a veteran of these small group processes, I got a specific suggestion into the discussion, and it went along the lines like this. It seems to me that there's an opportunity in terms of community benefit investment decisions that are made in the private sector by boards of directors and CEOs of hospitals for us to look at the community health assessment process and standardize the instruments such that they were inputs to models that could be developed that would be tailored to the circumstances on the ground for those hospitals and institutions in terms of their things, and estimate for them the potential impact of those private investments that are required under the IRS provisions. And that would be a very specific and tangible example of private policymaking or decision-making. We use the term policymaking to refer typically to legislators and governmental policymaking, but the whole premise of the roundtable is such that the task of actually improving health in the country is so complex that it's multi-sector and it requires decision-making and investments, and I would argue private policymaking as well as public policymaking, not only at the federal level and the state level, but within private institutions if we're to see impact. So therefore, the other thought I had, and it follows the line of the summary that, the excellent summary that was made of our group's discussion, is that the simplest model I know that applies here is actually the county health rankings one-page model that's referred to so often. And the prevailing public model that operates is that there's a box called healthcare, and then there's a box called health, and there's a line between them. That's the prevailing sort of model in healthcare delivery. And what this model that the population health group at Wisconsin has done is they said, no, that's not quite that simple. There's actually 4 boxes, and one of them has healthcare on it, and it's roughly 20% by one estimate. And we realize that that's based on a whole lot of sophisticated analysis, and that's an estimate. But that's an incredibly useful insight for private boards of directors for institutions, because it poses a challenge of how they construct their business and potentially reach beyond just healthcare delivery into the community for partnership with public health or with others. So is there a way we can use those proactive mental models that we want to create and really think about the depth of the kind of research and rigor that needs to be built in order to, say, model the relationships of education and the impacts back and forth between health, and use those simplified versions, not too simple, but the simple versions as tools for educating boards and other policymakers in terms of the salience and importance of investment decisions, both in the private sector, but also, quite frankly, in support of public decision-making of legislatures and governments.
Very interesting. Louise, that sort of ties back to the point you were making from your group's deliberations about the value of just establishing the predicate of what the mental model is before you even get into the heavy mathematical computations. Rajiv, we have a few more minutes.
Sure. Just following up on Dr. Kindig's point, Rajiv Bhatia from the Civic Engine. I think the question was, how is the healthcare, maybe the healthcare industry or other businesses looking or doing modeling that's relevant? I suggest I think it's interesting to look at how the healthcare industry is modeling or not modeling, and what they're modeling and not modeling. I think there's a lot of investment happening right now in data analytics and predictive modeling in the healthcare industry. I think it's notable how little of that modeling is focused on the upstream population health risks that we're talking about today. And I think that the notable conclusion from that is that I think from the perspective of the healthcare industry, the risks that were for societal population health isn't an economic risk for them. And I think that's maybe that's a generalization, but I'm wondering how I'm wondering how the models that were how that gap could be bridged. Yeah, thanks.
So it's not all about LDL levels.
Sandy Magnan. I was really intrigued. I think, JT, it was you that said one of your ideas with a scientifically based, cultural, societal, value-based system model. And thinking around, if we want people to understand, George and David, what you've talked about, the 20%, that getting more health care isn't necessarily going to make them healthy, and what kind of models to help the society understand that more health care and more expensive health care is not what's going to make us healthy. And if there are models that would engage the public in that kind of conversation, what that would look like, because I think that's getting to the cultural and societal values that we need to get to if we're really long-term going to change. So thoughts from the panel or thoughts from other modelers in the room about how we might do that?
Yeah, since that was mine, I'll say that we did leave it with a question. We didn't have a lot of time to really dig into how that might happen, because it seems like it's very uncharted territory. But I would probably leave that to others that might be more qualified to answer that question, because it's going to, as I think we said earlier, assigning a numerical value to values in culture is it's not something we've done in this context. So I wish I had a better answer.
I can tell you a little bit about some related issues in cost-effectiveness analysis. As you may know, in cost-effectiveness analysis, we use the quality-adjusted life year so that we can give credit not only for extending life or shortening life, but for improving the quality of life or for deterioration. And there's been a lot of ethical discussion around the use of even of life years, but particularly of quality-adjusted life years, because not everybody values the same health states the same way. Do disabled people value a state of disability different from the way healthy people would, viewing that state of disability? Should we take into, so there's that argument, whose weights should we use when we're adjusting or when we're calculating quality-adjusted life years? There are also distributive issues. Cost-effectiveness analysis, as it's normally conceived, just attempts to maximize the number of quality-adjusted life years for the population. Well, should we give more weight to people who are worse off to start with? And should we define worse off as worse off in health only, or should we define worse off as worse off in life in general? So there's a lot of discussion around that. I'm in the leadership group for the second panel on cost effectiveness in medicine and health, and it'll almost be true to say by popular demand, we're now going to have a chapter on ethics that goes through a lot of these issues. They can be examined in models. You can say, all right, let's assume we want to give a greater weight to people who are worse off, or let's assume we want to give a greater weight to people who get a larger individual benefit and less to people who just get small benefits. So there are a number of issues like that that I certainly are in the area of values. They don't begin to cover it all, but there's been a lot of thinking about them, and those particular issues could at least be explored in modeling by using sensitivity analysis to see how much difference it makes and to see how much you might be losing in terms of health for the overall population if you decided to pursue one of those values.
Excellent. Pam, in your words, we have time for one question and a succinct answer.
So I'm wondering if one of the reasons public health has been more behind the curve, as you put it, in bringing forth models to influence policy, with the single exception of tobacco, might relate to this, what seems to be a higher bar for rigorous evidence for a public health policy. The OMB kind of analysis and challenge and rigor. So I'm wondering if you, and then that's not a standard that's applied, for example, to economic models, which drive a lot of the decisions in our nation about, you know, what the Federal Reserve Bank or what anybody else does. I mean, those economic models are just, I mean, people just assume that they're there, and people go to Pandora, and that model's fine. You know, they may not even realize there's a model, but they're seeing the benefits, perhaps. So my question is, do you think it's because there's a perception that this issue of rigor, you know, which and the challenges that EPA has addressed, is that part of what's keeping public health a little reticent about going forward with models to inform policy?
Thoughts from our panel?
I would, there are at least examples of non-health models that get equally rigorous review, and I would suggest that just about anything modeled by the Congressional Budget Office, which does a lot of modeling for Congress to show what's going to happen if you adopt this program, what's going to happen if you adopt that program, gets very, very serious review and a lot of argument over you made the wrong assumption here and you shouldn't be using this methodology and that sort of thing. So it's certainly not only a problem for public health. I don't know enough about modeling in other areas to be able, except for the Congressional Budget Office, to be able to tell you. But I would suspect that if we looked more closely at them, we would find they're often scrutinized very carefully as well.
I think this has been a really fascinating discussion, and I think pulling together the themes across these work groups is going to be very helpful in summarizing this portion of today's workshop. I want to thank the rapporteurs for their excellent work, but please also join me in thanking the facilitators for leading the discussions earlier and the staff for somehow producing slides on such short turnaround. Thank you.